My name is Anissa Mitchell with PMD Alliance, and we are going to be having a conversation today around the things that people are not telling their physicians. We know that there are some things people aren't telling their doctors for many reasons, and we weren't really sure what those were, why they were holding back disclosing this information to their healthcare providers, what we might do to be able to break down some of these barriers. And so we decided to do a short survey, which some of you may have completed. You still can complete it, even though we are having the conversation today. This is something that we're looking at longer than just today. Kelly did drop that in the box. Your information that you share in this is anonymous, and we do want to learn a little bit about those things. And we're going to be talking about some of the information that we learned from the survey responses we've gotten so far. So with us today is going to be Dr. Yasar Torres-Yaghi. He's a movement disorder specialist at MedStar Georgetown University in Washington, D.C. He is in the middle of clinic and is en route to joining us in a minute. But I have lots of things to say before he hops on, and so he'll let us know when he gets in. And then also with this is our very own Kelly Papesh, who is a doctorally trained nurse practitioner. She has extensive experience in neurology and movement disorders, and she is going to be the voice of the advanced practice provider today. So we'll have a movement disorder specialist, advanced practice provider, and I am sort of your moderator, facilitator, but I'm also going to be sharing the voice of a clinical social worker. You may recognize my face of having been on NLO before, but may not realize that I do have many years experience as a clinical social worker, 14 of those specifically in movement disorders. So we are going to be tackling some of these topics today. And I also want to inform you that if you have comments, if you have questions, we've closed the chat today because we want to protect let you be anonymous. And so if you want to ask a question, if you want to share something that you're not telling your doctor, a reason that you're not telling your doctor, feel free to drop that in chat. You can even DM it to me specifically. I am going to be watching that, but nobody else is going to see it. And we will be keeping those things confidential. So we want people to feel protected and being able to share that information. So I will talk a little bit about the survey. So those of you who have completed, thank you. For those of you who haven't, the link is there. Please take a moment. It's very short to share your responses. Of the ones that have responded, 81% of you are not telling your doctor something. So that's pretty significant. What we found in the data we collected so far is that 26 of you are not disclosing because of embarrassment, 20% out of fear of what your healthcare provider's response will be, 20% because of denial or minimization of your issue. Other factors were you felt like there may not be enough time to address these sensitive topics with your provider, feeling dismissed by your provider, or not wanting to appear worse than you are. So before we get too far into this, I want to give you an opportunity to do an anonymous poll, very short. We want to know if you answered the survey, still feel free to answer this. If you have symptoms that you are not telling your doctor for any reason at all. So we're going to pop that poll up really quick. And I see Dr. Torres-Yaghi is here. So I am going to actually spotlight him for you and spotlight Kelly for you. And then you can see our poll. Kelly Merkel, can you please spotlight Kelly and I? Right, so we're getting some of those responses. So, and we're going to be discussing some of the types of situations today that are not being disclosed to your healthcare provider and some of the potential consequences of not sharing these things. So right now, we have 63%, it's not done, but 63% of you, no, almost 70% of you are saying, yes, you have some things that you're not sharing your doctor. So I'm going to give you another minute to answer this. Again, it is anonymous. All right, I'm going to give you 10 more seconds. Okay, I'm going to end this poll. So right now we have 68% are saying that you're not telling your doctor something for whatever reason. 32% are telling their doctor, I'm assuming. So that's good for the 32%. So let's tackle some of these things. In our survey, one of the top things that people weren't disclosing was related to mood issues. So we had 56% identifying a depression as something they weren't disclosing, 31% anxiety related issues as their challenge. Anger was also mentioned, as well as apathy. So some of the statements people made were, I feel depressed, guilty, and discouraged, and they aren't disclosing because of embarrassment and wanting to appear better than they are. I'm depressed and I have no support. They want to look like they're keeping it together during the appointment. I'm depressed. I lash out at those around me. And their reason is because they're ashamed and embarrassed. And this one is in particular of concern, and probably not the only ones out there that experience this, but this person said that they're closer from retiring from this earthly life than their doctor or family realize. And their reason for not disclosing is they don't want to cause distress in their family, and they don't want their physician to place them in an institution. And so we want to tackle these things. So thanks, Dr. Yaghi, for joining in. I know you have a very busy clinic, and for Kelly. So this is for both of you, but let's tackle the prevalence of depression and anxiety in Parkinson's. How is treatment approached? Why is treating this so important, not only in quality of life, but can it have impacts also on the physical aspects? So let's just launch into that.
Thank you, Anissa, and thank you everyone for being here to talk about such an important concept. I really, really think that discussing this and having my perspective, but as well learning from the polls and from this group helps me also in my own clinic to be able to address things that might not be, said by my patients. But I always try my best to recognize that, people have good days and bad days, and we have good weeks, bad weeks. Parkinson's disease is a type of condition that can behave differently depending on the day and depending on how we're absorbing medicine, and depending on, sometimes it's hard to know what exactly leads to more effect from the medicine or less effect from the medicine. And anxiety and other factors that might not be discussed or might not be conveyed as part of the visit are also really important. Even though I'm a movement disorders doctor, I take care of so many things that are not movement, right? What was mentioned, like the mood changes and the anxiety and depression, irritability or anger, and the fear of talking about those things, make it so that it may not have to come out while we're asking questions. It may not want to be discussed. Talking about those things oftentimes can be hard, and it can be very, very difficult for all of us as patients and care partners, sometimes even to figure out whether or not they exist. And so it's so important to address the relationship between anxiety and all the features of Parkinson's. Number one, anxiety is part of Parkinson's. And we have to think about Parkinson's as a complex condition that in many ways is like it's one condition, but it affects so many different parts of our body and so many different aspects of our body that it might be thought of as a multitude of conditions, not just one. Anxiety itself can be its own diagnosis, as can depression and a lot of other things. So anxiety specifically happens in Parkinson's disease because serotonin levels, just like dopamine levels can be low, serotonin levels can also be low. Those serotonin levels dictate how we feel, our mood, how it is that we cope with stressors, and how it is that we don't feel anxiety. If those serotonin levels are high, then we may not feel anxiety. On days where our serotonin levels might be a little lower, we might feel more anxiety, and that can really affect our circadian rhythm and our ability to sleep. And when we feel anxious, it can be like a vicious cycle, just like the question was, Anissa. How is it related? How's anxiety related to other features of Parkinson's? If we feel anxious, that can contribute to difficulty with thinking through things and difficulty with processing information. And that can make it harder to do things like walk. Or if we're anxious, we might see a little bit more tremor, or we might start freezing while we're walking. Another important aspect to anxiety is that it can happen as a result of wearing off. If anxiety is happening in between our doses, then wearing off, one of the symptoms can be anxiety, and that in and of itself can be part of a complex of off. So anxiety is so important to address and so important to recognize, which is why asking about the non-motor symptoms oftentimes helps us elucidate a lot of those things that are hard sometimes to come out. And sometimes patients find it difficult, but also emotionally, it can be very difficult to talk about anxiety, depression, and some of the mood changes that might happen with Parkinson's.
And I wonder, because they mentioned, a lot of embarrassment, shame, that whole stigma around having these sort of symptoms. How do we navigate getting people past that and being so hard on themselves? Because not treating it, like you just said, can have a significant impact. And so if people's doctors aren't asking them, and maybe they are, but they're not interested in telling them because of that stigma that they may be being applied to themselves. How do we help people navigate that?
Absolutely, and coming to talks like this, can be one of the first steps in figuring out how to communicate some of those issues to your doctor, your healthcare team of nurse practitioners, physician assistants. I mean, everyone is part of your clinical team. You know, kind of thinking about these things for in meetings like this can help us then say, well, if this is happening, how do I communicate that? And communicating effectively at each patient, at each doctor encounter with your doctor is so important because we only get a limited of time in the clinic. And so sometimes writing things down and recognizing what can go wrong is a good way to organize our thoughts. But when we go in there, it's oftentimes helpful to tell the doctor what it might feel like on one of your bad days. And that's why I ask patients often say, well, tell me about a good day of yours. And they might say, well, on a good day, things are doing well and I'm moving fine and there might be a lot of good things, good feelings. And then I say, well, okay, now tell me about a bad day you might have. Tell me about, how you feel when Parkinson's disease, as it's variable, I explain that in the clinic. Tell me about a bad day you might be having. So that might be a good way of going to the healthcare team and saying, hi, so how's it going? I'm feeling X, Y, and Z with my symptoms. On a good day, I feel like my levodopa lasts until the next dose, and I feel like things are going well. But sometimes on bad days, I feel more than just my Parkinson's motor symptoms. Sometimes I feel things like anxiety, depression, irritability, agitation, difficulty with sleeping. Those are the non-motor symptoms, and familiarizing yourself with the non-motor symptoms oftentimes can prepare us to know what to talk about. Also, sometimes people feel like these symptoms might not be part of Parkinson's, so they don't even know who to talk to or who to kind of talk to about it. Talking with your neurologist or your subspecialist, your Parkinson's specialty team is a very good place to start. Remember, as Parkinson's specialists, we take care of the whole body. It's not just the motor symptoms, it's not just the tremor. We are trained. We are trained to handle things like anxiety and depression and some of the other things that we may not want necessarily to talk about so much with our neurologist. But just remember, if it reassures us as patients, knowing that our healthcare team is well versed and trained to be able to tackle these issues as well should make it a little bit easier for us to talk about.
And I just want to say, something about the statement. The one person said it sounded like maybe they were contemplating, ending their life. And I'm assuming it's because it's challenging and you can be very depressed, and there's the issue of demoralization of what they're living through. How do we help people to express that or share that information when they're battling the fear that they're going to be institutionalized? The minute someone says, "Oh, I've thought about this," then their fear they're going to be, committed and be evaluated and held against their will, and that usually doesn't help much. Whereas if they have the opportunity to talk through that, I would love to hear. And I know, Kelly, we haven't heard from you yet too, so I would love both of you to kind of address this, because I've heard it from people before, and sometimes it's not like very strong statements of this is my plan and this is what I'm thinking about, but just little drops of information that we have to listen for, because they are suffering. There is an existential pain, not only from the symptoms of depression and anxiety, but just living with Parkinson's. So could we just tackle that for a minute, because I think that's an important statement that can't go undiscussed.
This is a very important topic, because it's hard, and Parkinson's disease can be hard, and it's hard on our patients, and it's hard on our care partners, and emotionally it can also be very hard. Sometimes, or oftentimes, as hard as some of the movement problems that can occur. And so it's important to address them, and it's important always to recognize whether or not they exist, which is why when we have our patient visits, it's important then to make sure that we are doing a good job of asking. And if doctors and healthcare team members aren't asking, it can be so important then for our patient and our patient's family to let us know, because the good news is if we can address what's going wrong, even when it comes to depression, anxiety, or even those feelings that Anissa was talking about, feeling maybe that we don't feel like we want to live, we feel hopeless and we might feel helpless. It's so important, because thinking about it as part of our condition oftentimes helps us understand that why it's happening and why it's much harder. And thinking about it from a neurochemical standpoint also helps us. Remember, when we have high dopamine levels and high serotonin levels, we feel good and happy. Both of those neurotransmitters or chemicals make us feel good, make us feel that we're happy, make us feel full of hope. And when we have low levels of that, that can make it so that we don't feel those experiences. We feel low, we feel anxious, we feel depressed. It's a neurochemical issue in many ways in Parkinson's disease. Knowing that there are treatment solutions to the problems oftentimes might help us really address them. The good news is that medicine really works. Medicines that help stabilize serotonin. And our medicines, if we can do our best at maintaining dopamine levels, maintaining the tone throughout the day of those chemicals with medicines, can help reverse or improve the symptoms that we're feeling. Also, there are so many treatment solutions aside from just medicine. There's things like supportive measures that can help us, making sure that we're getting enough vitamin D and the sunlight, and making sure that we're getting enough exercise and improving our sleep quality can all contribute to improving our overall emotional health and our mental health. And then addressing things that have to do with more severe symptoms of depression, like feeling like we want to end our life, is so important. We have to recognize that in patients so that we can address it. It's not uncommon for us then to seek help from psychiatrists to help us even more understand what can be done to improve things. Odds are, if we address things, the hopeful and positive optimistic view is that things can improve with treatment, and we can turn things around, and we can make our patients feel better. So addressing the symptoms is the first step, and then recognizing that there are treatment solutions, not just treatment oral medicines, but other treatment solutions, is also very helpful. Another thing that we utilize now in our clinic and that we may need to seek help from is someone like a social worker. If there's access to a social worker within a department or within a clinic, oftentimes social workers are really well trained in helping us with that support mechanism and resources. A lot of the times resources can be so invaluable when things like this occur. And speaking with someone that really knows about resources or the things that we can do to help is so, so important. And then also knowing that there are ways to talk through things. Many social workers are also licensed in doing things like clinical therapy, doing visits and talk therapy, and being able to help us emotionally handle the disease and the condition. And so all of these things are aspects of our care. So it's not just us as clinicians that are taking care of our patients, it's a whole team. And people that help us with emotional health are imperative as part of that team.
Yeah, and I will just say that I believe cognitive behavioral therapy is very helpful when people are dealing with depression and anxiety. So, and just a real quick question before we move on to the next thing that was identified. You know, Kelly, people that deal with this, you know, I know I've had this experience before, and someone did message me and, you know, say, you know, what do you do when you have someone, a spouse who is experiencing symptoms such as anxiety, and they're not disclosing it. They may have a bit of denial around that. That was one of the things that we did surface as an issue, was denial or minimization of problems, and they're suffering. Their loved ones are seeing their suffering, but they're not sharing it with the physician. And so that causes a very challenging dynamic in the relationship. And it's certainly, you know, as we've talked about, has an impact.
Yeah, thanks, Anissa. I think it's a very challenging topic, mood in general, especially in Parkinson's disease. Dr. Yaghi said it best, you know, a lot of things mask each other. And in Parkinson's, we often see apathy, depression, anxiety. Sometimes we see slowness of movement, masked face that some people will interpret as depression or apathy when really it's just the physical symptoms that are changing. And so it is important to me in practice to do a really, like a deep dive into every review of system. So asking, how is your mood? For example, are you doing the things that you've always been doing? Has there been a change? Are you not going to things that you used to go to? I have had it where a spouse, then they leave the appointment and a care partner might write to me on a message in the portal and say, they didn't mention this, but I think that they're struggling with anxiety or depression. I make it a big point then to chart that in their, in their notes. We may come up with a solution in the meantime, but if not, that's the first thing I bring up at the next appointment. You know, I just really want to dig deeper into this because a lot of people aren't necessarily familiar with this, or you might not recognize these symptoms in yourself because you think it's part of Parkinson's. Well, not everything is just, doom and gloom. There's a lot of hope in Parkinson's, movement wise, and with all the non-motor symptoms. And I think people, if they start understanding and recognizing that, they're more likely to say, oh, well, maybe I can get something that will help me with this. A lot of people are worried about pill burden, polypharmacy, so they don't want to bring up issues. But again, it's not just medications, it's exercise, it's therapists, it's support groups. There's a lot of options. So I would say if you're a spouse of somebody and you're worried about that, continue to advocate. And if you are listening to this as somebody who is experiencing those symptoms themselves, it's important to speak up because there are options, and there's many options for a lot of the things that we do try to treat.
You. And I will say this because on the other side of things, there are family members that also live in denial where the person with the diagnosis actually is trying to tackle the things. One of the things that I did a lot as a social worker is just meet with the family and help them process through that, and the importance of working together as a team. Everyone addresses their processing or grieves and copes with things and adjusts differently, but working together as a team, for the good of the person with the diagnosis and the whole family is very, very important. All right, so I'm going to move on to the next symptom challenge that people aren't disclosing, and these are around the autonomic nervous system. So we're talking about GI issues, urinary issues, and sexual dysfunction. So we found in this survey that 31% of people reported GI and urinary issues, 39% reported sexual dysfunction. So some of the comments made were, I have erectile dysfunction, but I'm not telling my healthcare provider because I'm embarrassed. The other person said, my bowels are a roller coaster. I have major GI issues. I'm not telling because the doctor's too focused on my meds and are dismissive. Another person says, I'm dealing with major sexual dysfunction, but again, embarrassed. Sexual relations are a problem. It's causing relationship issues. But the person with Parkinson's, this is the spouse talking, is in denial of it and is embarrassed about it. And then last person said, I have urinary issues and incontinence, but I'm not telling the doctor because I'm too embarrassed. And then one of the reasons, and I added this, was their urologist or the movement disorder specialist did refer them to the urologist, who then just provided pills and surgical options, but felt like no one was offering other methods to otherwise address these things. And so I'm going to bring that up from my perspective in a minute, but I want to tackle first some of these significant impacts on quality of life. And we're talking about, urinary issues, GI issues, sexual dysfunction. Some of them are quality of life issues. Some of them actually have physical impacts. So when we're dealing with those things like urinary issues, Dr. Yaghi, can these actually have negative impacts physically? Can these potentially cause people to have falls, urinary tract infection? I mean, it's beyond just having incontinence issues. What in regards to urinary function can happen in Parkinson's, and even GI function, getting medications, can actually negatively impact the people if they're not telling their doctor that this is going on?
Yeah, it's an important discussion, and hearing about the results of the polling, it's helpful, and recognizing that, a lot of what we talk about can feel like things we don't want to talk about with our doctor, right? So when it comes to urinary change or sexual changes, sexual dysfunction, that can be, as Anissa was saying, and as the polls were saying, it can lead to a feeling of embarrassment, and that is completely understandable. And when we're talking about certain aspects of our body, it can be hard to discuss them, and hard really to open up and talk about, especially when, like Anissa said, especially if we feel like maybe we're already on so many medicines, and maybe it's going to lead down to more medicines or more surgeries and things that might lead us down a longer path of treatments and different other things. So it's true, the concern that, if I say something, then we may have to kind of go through a whole process of things. It's not uncommon for sometimes me to refer my patients either to a urologist or a gastroenterologist, and patients might tell me, but I'm already seeing so many doctors and I'm already taking so many pills. And that in and of itself also can be a reason why we may not want to always talk about some things that might be going wrong. I think it is important to remember that our clinical care and our clinicians are subspecialty clinicians that are trained in understanding the condition, and recognizing that a lot of the things when it comes to urinary changes, GI changes, urologic changes, changes to our sexual function, all of those things can be part of the condition. And remembering that our clinical team is there to help, and remembering that we're trained and we think about these things not just from a standpoint of what's going wrong, but also we think about this in a very scientific way. How is it that we can make a change and improve things, recognizing what can go wrong? And as we said, as I heard that was said, it's not always a treatment solution. Are there other things that can be done? Absolutely. If we're having trouble with urination, there are a lot of what we say non-pharmacologic things that can be done, right? For example, if we're urinating at night a lot, sometimes making sure we get hydrated, but not close to evening time, right before bedtime, can help, so that maybe we're not having urination and increased urination at night. The other thing that might happen is knowing that if we are urinating a lot, for example, at night, which sometimes can happen, knowing that keeping a night light on in the room, for example, so that we don't fall in the dark as we're trying to get to the bathroom quickly. Anissa was also asking about whether or not urinary changes or increased urinary frequency or increased urination can lead to falling or can lead to any impacts like that. And the answer is yes. If we're trying to make it to the bathroom quickly and we're in an off episode, or if we're having trouble walking, that can make it so that we might fall. Or at night, if it's dark and we're trying to make it to the bathroom and we didn't turn on that night light, that can be something that can increase our risk of falling. So all of these things may in fact have treatment solutions that aren't just oral medicines, and things that we can do to help mitigate risk as a result of some of these factors are things that we should hope to get from our clinical team. And so hopefully if we think about it like that, from that end, knowing that our clinical team is there and prepared to be able to handle it. And maybe you might want to say and formally say or ask, are there things that can be done about urinary change, for example, that aren't just taking another pill? Because yes, there are things that can be done. For example, it's not uncommon for us to put in a referral for exercises done by a physical therapist called Kegel exercises. Sometimes that can help strengthen those muscles in the urinary system so that we don't leak. And so there are so many things. So it may be important to try our best to broach some topics, knowing that, you know, our doctors and our nurse practitioners and our physician assistants are always there to help and always have, you know, our thinking caps on. And we're not there to think about things in a negative way. So if we're told something, our goal is to really kind of try to find the positives and our way out of things and the optimistic approach to things.
And I think you answered one of my questions that was coming up when you mentioned the Kegels, and that was one of the things that could potentially be done is like pelvic floor therapy. And that can be also, I've heard, have assistance for some people in regards to sexual dysfunction as well. Are there other non-pharmacological treatments that are practical that people can use? And I am going to say one thing before I ask this of Kelly. I will say that a team member that maybe on some movement disorders teams, not others, but is something to look into in your community is as a sex therapist. And I know some people get a little uncomfortable with the concept of a sex therapist, but basically what this is just a therapist who focuses on intimacy and helping people navigate some of these challenges. So there's the physical aspect of this, and then there's the emotional and relational aspect of it. And so they can actually be a huge help and contribute to the overall a picture of managing this. But Kelly, real briefly, because we have so much to cover, but can you tackle a little bit maybe some of the practical things also that you might suggest to people dealing with some of these issues?
Yeah, I mean, really, you said it. The therapy options outside of speaking to social work to get resources in your community and talking to your provider, there are opportunities for different types of therapy, physical therapy, sex therapy. But I think, you know, one thing that is just so important, I just wanted to mention to keep in mind is that this is all of these, you know, whether it's sexual dysfunction, hypersexuality, or if it is urinary changes in dysfunction, or constipation, GI issues, these are significant to quality of life. And so if they're not brought up, it's really difficult sometimes to address them. Often these are the things that, you know, like we just change one little thing and there's an improvement, because a lot of these can affect getting out of the house, doing the things that you want to do. They can affect relationships. And the biggest or the most important step is truly addressing those. And then talking about that. What is it that your goal is? And understanding from a a care partner or a person living with this, what is their goal? And then working towards that goal. So whether it's sending out to a referral in the community, whether it's something that we just that needs to be talked through, whether it's looking at their medications that they're on. Oftentimes a referral to a specialist, sometimes they don't like to go to another appointment, but that can rule out that maybe it's not related to Parkinson's, because sometimes it isn't. And, we can't blame everything on Parkinson's disease, although all of these things can fall under autonomic dysfunction within the disease. There may be a true issue, like a male over 60 who may have, a prostate issue that's taking place and contributing. So sometimes those referrals help us too, and they help guide us in the treatment. It's not always Parkinson's, but sometimes it is.
All right, so I'm going to move on to the next one, and that's around cognition. And also I'm going to include in this, because of time, hallucinations and delusions. So basically, some of the comments made is that I'm not sharing my cognitive problems with anyone because who wants to hear that their abilities are declining? I am seeing changes in cognition and I'm having hallucinations. I feel like I've failed and I'm embarrassed. And then this person, and many people just said, yeah, cognitive issues. They didn't really dive into it, but this person said lapses in cognition. And I feel like talking about it is just going to open up the floodgates. So I know, and we didn't get a lot of comments specific to their experience with hallucinations and delusions. It's another area where there's a lot of fear and anxiety around that. Some of these are the most debilitating things in Parkinson's. So I just want to say that, if we could tackle a little bit about managing that fear. What can you talk a little bit about cognition, like how prevalent are cognitive problems, and I know we don't have a ton of time, but like just some of the spectrum of problems that could happen, mild changes to dementia, because I know people are just scared to death about this, and not telling isn't helping. So let's tackle that just a minute.
Thank you, Anissa. Yeah, and I was listening to those responses, and it can feel oftentimes that if we talk about something, then it might open the floodgates, or we might uncover something that is really hard for us to process. And a question I get in the clinic is, does Parkinson's mean I'm going to develop cognitive change or develop a diagnosis of more severe cognitive change? And the answer is no. There are different forms of Parkinson's that may or may not lead to cognitive change, although we're always on the lookout for it. In fact, in the clinic, we do our best to create an objective measure to understand whether or not cognitive impairment may be kind of underlying. Even our first visit in the clinic, oftentimes we may say, well, let's get a baseline understanding of your cognitive capacity so that we might be able to monitor it moving forward. So recognizing whether or not cognitive change is present is very, very important. Also knowing that it can span. There are patients that may just be mildly affected and feel just some changes in their cognitive capacity, maybe slowed processing. We call that bradykhrenia, just slowed processing. Executive function, our ability to think through things and follow a sequence of commands, can really be affected in people that have Parkinson's. Things like attention and focus, maintaining attention and focus, can be impaired, in addition to memory loss. But oftentimes in Parkinson's disease, it's not so much long-term memories that are lost, but short-term memory dysfunction that can happen. So these are the things we look out for, although it's very, very important to recognize whether or not these features are happening because of Parkinson's or because of another reason. Checking B12 levels, for example, can be really, really helpful. If people aren't eating a lot, it might be important to recognize whether or not a B12 deficiency is at play, or looking at thiamine or some other nutritional changes that may happen in Parkinson's. So recognizing what's going wrong can help us see if there's something even nutritionally that we can do to change things. recognizing sleep quality and whether or not sleep apnea exists, whether or not we're acting out our dreams also can have an impact on our cognition, right? So if we're not sleeping well, or if we're urinating a lot at night, nocturia, our nighttime also is something that we talk a lot about to make sure that we are sleeping and we're sleeping soundly, that we're not snoring and that we're not waking up gasping for air, which can happen with sleep apnea. Sleep apnea can be part of Parkinson's. So these are the things we look out for, which is why it's important to recognize that maybe the treatment solution isn't in fact medicine. Maybe it's another thing that we may recognize. But knowing whether or not cognitive impairment exists can be helpful, because guess what? There are treatment solutions. In fact, we're so lucky that medicine works. In fact, for Parkinson's disease cognitive impairment, medicine can really reverse clinical symptoms and improve things. Sometimes patients come in and say, or patients' partners or family members say, oh my goodness, I have my dad back, I have my mom back, or my partner back. You know, I feel like we turned back the clock many years. Cognitive function is so much improved in comparison to what it was before we started treatment. The medicines like acetylcholinesterase inhibitors can be really, really helpful. We might want to recommend even a speech therapy referral to do cognition therapy, different than cognitive behavioral therapy. Of course, that's different because that's something that we do like talk therapy to talk things through, more for emotional health. Cognitive therapy are actually our speech language pathologists implement training exercises to keep our mind sharp. That is something, that's a referral that can be given. That's not strictly just a medication referral. Now, you broached on something very important, Anissa, about psychosis or hallucinations and delusions too. That is very important to address. It's not uncommon for a patient or a patient's partner to not tell unless we ask. You know, in fact, it's something that we are trained to look out for, because if it exists, then there are treatment solutions for that as well. The medicines actually work. There's an FDA-approved medicine that can get rid of hallucinations and delusions in Parkinson's. So there are so many aspects here that are important, and I know they can be really hard to talk about. But recognizing that there may be ways to treat it that are effective ways of treating might allow us then to start discussing what can go wrong so that we can figure out how to fix it.
Yeah, and I was just going to add on to that. I agree. It's so important to mention it because there are therapies and treatments available. Also, when it comes to cognition and psychosis, you know, those to us can both indicate something different, not just a progression in disease. For example, if somebody is showing signs of psychosis and it's more acute, meaning it just just happened, this may demonstrate to us that there is an infection taking place, most commonly seen like a UTI, or that there's something else going on internally, physiologically. Same thing with cognitive changes. Are you getting the right sleep? Is there depression? So there's some of those things that we need to know about them, because some of those could be really significant, and they may need to be treated or addressed sooner than later.
Awesome. Okay, so I'm going to dive into impulse control disorders, because that was another one that had some people indicating they're not disclosing. So one person said, I'm not disclosing how fast I drive on the express lane when they're empty, 120 miles per hour, because I'm afraid they'll penalize me. This person said, I was on a dopamine agonist and I had impulse control issues. I mentioned some of them, but not all of them. I had an affair. I had other impulse issues, overeating and spending, that I did mention, but I didn't mention the other because I'm embarrassed. This person said, my husband with Parkinson's takes too much dopamine. It causes him to be overly sexual. He thinks about and wants sex constantly. It's led to compulsive behaviors such as watching porn and engaging in inappropriate online relationships. He has no control, won't stop, but he's embarrassed, ashamed, and afraid they will reduce the medication, which could impact, function. So these things are touchy because they are very, very impactful in personal lives. I've seen relationships come to a head because of this. And even subtle things that go on can cause significant strain in relationships, whether it's, you know, a hypersexuality or overspending, gambling, anything. So how do you navigate these kind of situations when people are clearly know that there's something going on, but they're not disclosing? How do we overcome that barrier, knowing that this can be addressed? Can you talk about how this can be addressed, how this can actually be improved for people if they would be willing to share?
Yeah, and all of those examples that you gave, you know, could be real world examples, you know. So it is important to recognize that our medicines can increase our inability to control impulses. And that can mean more hypersexuality, or it could mean that we might be having more trouble controlling our urge to eat or spend money. Sometimes we might feel so much energy, like a euphoria, that can sometimes happen because of our medicines that we're trying to use to help people stay stable, to help them with their Parkinson's symptoms. But it's true that one of the things we always have to look out for and we screen for are impulse control issues. And in some cases, the treatment solution is to minimize the amount of levodopa that we might be on, or some of the other medicines. Oftentimes, however, we might also use, you know, those resources, those support resources that we might have. Recognizing, for example, whether or not the urge to eat exists, and the increased urge to eat can have very strong implications. Recognizing it can lead us down the road of trying to improve weight gain, for example. If someone's gaining weight, there might be certain things that we can do. Just knowing whether or not someone's having trouble controlling their urges to eat can be very important. Also, with the other thing that can be very important is seeing if, you know, if there is stress on the relationship because of this impulse control or difficulty with controlling our impulses. It is important maybe to have things like Anissa was mentioning, doing talk therapy, but as a couple, or family therapy or couples therapy, to try and go through some of the issues that may put a strain on the relationship. The increased sexual urges also can be something concerning, especially what was mentioned, like if someone is experiencing the urge to find another partner, for example. So these things can happen, and so it's important to discuss them. It's important to figure out whether or not they exist, because the first step in understanding whether or not they're present oftentimes can help us then say, well, for example, if we're eating too much, how is it that we can fix it? You know, first recognizing that we have an increased urge to eat. It's not uncommon for me to ask about that, and a patient say, well, you know what, it's true. You know, I'm having trouble. You know, I've always wanted dessert after meals, but now I can't stop myself, and I'm having it at least once a day. So just knowing, if I tell a patient, well, that could be part of the concept of impulse control problems. It's hard to control impulses. Recognizing it oftentimes can help the patient. When they recognize it, that they can tell themselves, oh, wait, I'm having difficulty. My healthcare team told me that, in fact, this is part of the condition. It might be made worse with our medicine. So sorry about that. So that might be something that becomes very, very important. So basically, recognizing when something exists can have a very strong impact on being able to help figure out how to fix it. And also remembering, you know, that our goal always is to improve our patients' and our care partners' quality of life, even when it comes down to things like spending too much money or overeating with impulse control issues. So these things can be part of the condition, and doing talk therapy or therapy in general also can really help us deal with some of those feelings that we might be having.
And I know it's a very delicate topic, but people are not sharing because the shame around it, the embarrassment around it. And I would like to at least help reduce that, that it is a part of the treatment, can be part of the experience with Parkinson's. And there's many people out there that are suffering in silence. We don't want you to suffer in silence. We want to help you navigate it, because we can work with you to, movement disorder specialist, your APP, that can help you navigate this and adjust things, because it does have an impact on your life and your relationships. And so I know it's tough, but we really feel strongly about having these hard conversations. Some of the other things that people have shared, around falls, there were people, because we're running out of time, talking about not sharing alternative treatments that they're using because they're afraid their physicians wouldn't agree with it or understand it. They don't have supportive spouses, and they don't want anyone to know that they're managing this alone. And that is something, I think from a social worker's perspective, I'm always looking out for, as, what are people's support system, and, how much support they can, give. And if you are the person that's their support system, understanding what your limitations are. It goes both ways. And so we want to be supportive of both the person with Parkinson's or movement disorders and the care partners, the family members involved. And so if people aren't sharing these things, they're not talking about their struggles and their concerns, then we can't help them. And I know somebody mentioned earlier, is it always on the person to disclose that? Well, there's so many things that can present itself as somebody having a movement disorder that with the time that we do have, we can't ask everything. So I think you guys do a fantastic job of screening for these things on a regular basis, and we'll continue to do so. But I think it's really important that if you are challenged with something, and if the doctor is asking you to go ahead and be honest about it so that it can be addressed. So again, I don't know if you have any last minute comments about those things like falling or alternative treatments, or, being willing to share any of these things. And I know we didn't cover everything, but you guys tackled a lot in this. And then we have a last minute poll. So I'm going to give you guys a couple more minutes to share those last thoughts.
Yeah, I guess I would just say that as a nurse practitioner in movement disorders, we've seen it all, Dr. Yaghi, right? We've heard everything. We hear from the care partners, we hear from the people living with Parkinson's, head to toe, things that could be challenging them, whether it's non-motor or motor. You're not alone in this, and we're hoping that what this survey does, is just really bring awareness to the fact that if you're feeling something that you heard today, or you resonate with something, it's because you're not alone in this. In fact, I think every single thing we've heard, it's not the first time. I can guarantee you that. And so that being said, don't be embarrassed to bring that up. Easy for me to say, but it's something that we've probably heard multiple times before, and we might even have learned a trick on how to help solve that. If it's not something that we can refer to, we might be like, oh yeah, we had a patient that did this, and now I would recommend you try this too. We learn from our patients just as much as you learn from us, and I think being able to share with us is extremely valuable. And as Anissa was saying, people that don't have support, sometimes you don't feel comfortable telling your provider or your care partner. I would really seek out maybe a support group. That's something where often you feel safe, you feel like your comments are safe, but you don't really have to share yet with those that are really close to you. So it might be a good option to gauge, how to approach that topic.
Well, if you all are ready, we have one last poll question for you. And we'd like to know if talking about the importance of sharing these issues with your healthcare provider in today's program impacted at all your willingness to communicate. So I'm going to give you guys a few minutes, and then while we're doing that, I want to thank Dr. Torres-Yaghi and Kelly for sharing their thoughts and expertise on this. And I want to thank all of you for the comments that you've sent in. Some of them we didn't get to. I actually saved them because this, like I said, is important information. We're still gathering your information. So again, if you haven't filled out the survey, please do so. We're actually having a topic at our advanced therapeutics and movement related disorders for our healthcare providers there to understand your experience. And so we're taking the information from the survey in today's program and letting them know what are people struggling to disclose and why, so that we can come up with better solutions to help. So give you 10 more seconds if you can finish this. So far, I'm happy to see several of you do feel like this had an impact. A couple unsure. It's okay. I think this is an ongoing conversation. And I'm going to go ahead and close the poll. So thank you, everybody. And again, thank you to Dr. Torres-Yaghi, to Kelly, and I know you all know our tradition here at PMD Alliance, and that is to give the wave of gratitude to our speakers. So I want to first give a wave of gratitude to you all, because this was a hard conversation. And I know that you guys have shared some things that I appreciate your candidness. So love and thanks to you for being willing to share that. And then I want to invite you to give gratitude to Kelly and to Dr. Torres-Yaghi today for this. And I appreciate all of you, and I hope you have a wonderful evening.